Dear friends, it's indeed a pleasure to be part of the Visicon 2020 virtual platform. My topic of discussion today is cephalous incompetence with post-thrombotic deep veins. I have no conflicts of interest. The post-thrombotic syndrome, with manifestations of pain, swelling, hyperpigmentation, and ulceration, is the most important long-term complication of acute deep vein thrombosis. Severe manifestations of post-thrombotic syndrome occur in 7% to 23% of patients following DVT. Severe complications like ulcerations occur in 4 to 6% of patients post-DVT. Ambulatory venous hypertension, the common denominator of post-thrombotic skin changes, appears to be related to both residual venous obstruction as well as deep valvular incompetence. The combined incompetence of the distal deep veins and the superficial veins are especially associated with significant post-thrombotic skin changes. What are the mechanisms of superficial venous reflux following DVT? Firstly, there could be direct thrombotic injury of the saphenofemoral valve. Secondly, an effect of increased venous pressure due to proximal deep venous obstruction or deep venous reflux on the superficial venous system. Thirdly, pressure transmission through incompetent perforator veins, especially the distal perforators above the ankle. And lastly, degenerative changes in the superficial veins, which are unrelated to the index thrombotic event. There was a very nice seminal paper which was published in the Journal of Vascular Surgery in July 2000, which studied the association of deep venous thrombosis and superficial venous reflux, and was authored by Dr. Mark Meissner and others. 130 lower extremities in 66 patients were followed for a mean of 48 months. Subjects included 32 men and 34 women with a mean age of 48 years. Thrombosis was unilateral on the right side in 32 patients, unilateral on the left side in 31 patients, so more or less equal, and bilateral in about 5% of cases. Evaluated limbs included 69 with an acute DVT and 61 uninvolved limbs contralateral to a unilateral DVT. The follow-up here shows the degree of superficial venous reflux. As we can see, at 12 months, those patients who had DVT along with GSV thrombosis, as demonstrated by venous ultrasound, showed a 47% rate of reflux. In comparison, when there was DVT with no evidence of GSV thrombosis on ultrasound, the evidence of reflux was only seen in 2% of patients. On the other hand, in the uninvolved limb, surprisingly, 7% of patients had 7% of patients had GSV reflux. When these patients were followed up at 3 years, the reflux in those patients who had DVT and concomitant GSV thrombosis increased to 62%. In those who had no GSV thrombosis, increased from 2 to 14%, and in the uninvolved limbs, it also increased from 7 to 12%. At 5 years, this further increased in the first group from 62 to 77%, and then carried on at the same level for another 4 years. Similarly, in the patients who had DVT but no GSV thrombosis, increased from 14 to 29%, almost double, but then no further increase. So remotely, the DVT did not affect superficial venous reflux. The differences between the two groups of DVT and GSV thrombosis and no GSV thrombosis are statistically significant with a p-value less than 0.0001. However, in comparison with uninvolved limbs, the relative risk of reflux is significantly greater only for those limbs with GSV thrombosis. The presence of GSV thrombosis therefore significantly influences the prevalence of GSV reflux. Does the presence of superficial venous reflux affect the long-term outcome in a case of DVT? If you see from this table here, this is a patient with great saphenous vein, reflux and no reflux, And this is the class of seat classification, class 0, 1, 3, 4, and 5. You will see the majority of patients who had reflux in the GSV, the post-thrombotic changes were significant as far as class 3 and class 4 were concerned. Even the lesser saphenous vein, if studied, will show a similar result. And we take the overall superficial reflux in great saphenous vein and lesser saphenous vein, you will see the majority of patients had changes of class 3 and class 4, which shows us that if there is concomitant superficial venous reflux in a patient of DVT, the long-term post-thrombotic changes are more severe. How do we go about treating a case of post-DVT superficial vein reflux? First of all, it should be directed to only symptomatic cases with swelling, pain, or presence of a venous ulcer. And amongst these, there are two groups of patients. Firstly, those with residual occlusion of the proximal deep veins. Amongst these, if there are adequate collaterals which are present, then treat the superficial venous reflux first. On the other hand, if there are inadequate number of collaterals, then treat the deep veins first, that is, recanalize the deep vein. What about those patients who already have recanalized that deep veins? There is data to show that deep venous reflux significantly decreases after treatment of superficial venous reflux, and therefore our treatment goal should be treatment of the significant superficial venous reflux in such cases. In this paper published in Journal of Vascular Surgery in 2003, they addressed the question, how often is deep vein reflux eliminated after saphenous vein ablation? And they showed that in patients with concomitant deep and superficial venous reflux, saphenous vein ablation results in resolution of deep reflux in about a third of patients, quite a large number. It also leads to improvement in ulcer healing. Another paper published in Journal of Vascular Surgery in 1996, which studied the hemodynamic and clinical improvement after superficial vein ablation in primary combined venous insufficiency with ulceration. And they showed that superficial and perforator vein incompetence accounts for a substantial and correctable component of venous insufficiency in limbs with combined deep and superficial vein reflux and venous ulceration. So in conclusion, friends, superficial venous reflux in the setting of acute DVT may have at least two mechanisms. One, directly related to superficial venous thrombosis. This may be occurring more commonly than is clinically recognized by us. And secondly, due to independent degenerative processes which are also observed in non-thrombosed veins. And this may be an equally important factor. Remote DVT appears to have little effect on the development of superficial vein reflux. And alternative mechanisms such as those related to proximal reflux or obstruction and incompetent perforator veins may have a little role in the development of superficial venous reflux. Superficial venous reflux post-DVT adds significantly to the possibility of development of post-thrombotic syndrome, as well as increases the severity of the post-thrombotic sequelae. Treatment of secondary superficial venous reflux will need to take into consideration many factors regarding the current status of the DVT. And mild to moderate deep venous reflux can be significantly reversed by treatment of the secondary superficial venous insufficiency. I thank you very much for your attention.